And
Sorry.
we can, Dr. Hart, but you may want to go up to the top of your screen where it says display settings. Click on that and then say switch, because right now we're also seeing your next slide in the slide deck.
Okay, sorry. I'm not sure. How about now?
I think it's just about, and there we go. You've got it.
Okay, sorry about the delay, you guys. Okay, so yeah, today I'm just going to review a few things with you guys, and I'll have some questions for us to go through at the end of each review section. So we're going to cover a few fundamentals of anatomy, histology, and embryology. These are all your learning objectives, the regional objectives. These are everything that we're going to be covering, along with the questions associated with them. And then for the anatomy part, it's really just your learning objective wants you to know what radiology is and how we use it. So in general, radiology is just sort of any kind of medical imaging technique that we use to determine, what internal anatomy structures are there and how they're doing, how is their physiological function, if there are any issues. So there are 4 different types of imaging that are really, really common. First and foremost, X-ray based imaging is probably the most common, followed by computed tomography, which is CT scanning, then ultrasound, and then magnetic resonance imaging, which we often just call MRI. Now, it doesn't matter which of these 4 you use, all of them are basically going to have an interaction between energy and how the tissues sort of ping back energy signals. So based on the altered or attenuated energy signals, we're going to see those internal structures and look at how they're functioning. So let's start with the most common, which are X-rays. Generally, you're going to stand a person up against a plate. That plate's the detector. You'll have the X-ray source. And then X-rays are going to be passing through that patient's body, and it's going to be captured by that detector. Now, how it's going to appear is all based on the tissue density and that X-ray attenuation. So you have some tissues that are really, really dense tissues. So I want you to think of like bone. When these X-rays are hitting the bone, it's absorbing a lot of it, which allows very few photons to pass through and reach the detector. When that happens, you end up with a very bright white on the image, which we call radiopaque. Now, then there are less dense tissues, just kind of think of any soft tissue, organs, things like that. These are going to absorb fewer X-rays, so more of those photons are going to pass through and be detected by the detector, and they're going to appear dark black, or at least just gray, and can be up to black. So this also is going to vary depending on the tissue type. I mean, you can see here, like lung tissue versus heart tissue. Obviously, lungs will have air in it too. Then you have like the liver that doesn't, have any kind of gas in it. So it'll all just depend and vary, but you can see some soft tissue. However, X-ray is like phenomenal for bones. So we really like to use it for the skeletal system, assess for fractures, things like that. If you do want to check out soft tissue with it, you can use some contrast enhancements. We have contrast media like barium and iodine. You can use it to assess intestinal issues, vasculature, things like that. Now, on the great side of things, this is a super cheap method for imaging, and almost all medical facilities have them, so widely available. Then we have the next step up. So then we have computed tomography, or CT scanning. It is still basically a fancy X-ray. So at this point, you have a rotating X-ray source and detector that are going to go around the long axis of the body and they're going to acquire multiple cross-sectional images. Now, because it is picked up and reconstructed, through computers and everything, we basically can rebuild a 3D representation of all these internal structures and view them in whatever plane is best for you. So there's sagittal planes that separate left and right. There's coronal or frontal that separate posterior and anterior. There's transverse that separate cranial caudal or superior inferior images. You can view whatever you need to view based on, whatever the problem is. So again, this is really, really great for skeletal. The bones really, really pop. But this is also pretty decent for soft tissue. It's something that's used often for the brain to see if there's hemorrhaging, edema, just swelling. But even here in this image, you can see like the paired kidneys, you can see back musculature. So it's pretty decent for soft tissue as well. And like X-ray, you can use contrast media to help highlight some of those soft tissues. Now, this is better than X-ray imaging just for the anatomical detail you get, but it's also really great because you can segment out just the things you want to look at. So if you just want to look at the kidneys, or if you just want to look at the vasculature, you can pinpoint those individually as well. Now, this is a little more expensive and it's a little less available, but typically larger clinics and hospitals do have them. So, all right, and then we have ultrasound. So now we're moving away from X-rays. This time we have high frequency sound waves, and they're made by this transducer that we place up against the skin. We often use ultrasound gel to help improve the signaling. So most are going things of ultrasound for like fetal monitoring, which is a very common use for it. But it can be used for other tissues as well. So this is really great for soft tissue. Basically, those sound waves are going to travel into the body. They're going to be reflected back off of different tissues, and they reflect back differently depending on different tissue types. And those echoes are going to be picked up by that transducer and processed, and they create an image in real time. So since it's in real time, that's why for like fetal monitoring, you can see the baby moving, or down here, we're looking at the heart as it's actually beating in time. And it's also great for fluids. So if you use Doppler ultrasonography, it's going to use those frequency shifts to detect motion, direction, and velocity of moving material, so blood flow. So yeah, this would be like the number one choice for soft tissues, especially superficial structures, because they reflect back easily. This is also going to be something you want to do when radiation is not recommended, like for fetal ultrasounds. And this is also fairly cheap. It's pretty low cost. Again, no radiation, so that might be preferable depending on the problem. And this can be done anywhere. This time you don't need to bring the patient to the machine. You can bring the machine to the patient. Hence why it's often called bedside ultrasound as well. Then we have magnetic resonance imaging, the MRI. This is a step up. This one is a large magnetic field machine with radio frequency pulses that are being sent towards the body, not X-rays. So you put the patient within a circular magnet, and all those radio waves will interact with the hydrogen protons within the different tissues of the body. So some tissues have a high proton density. There's a lot to interact with. So think of like fat and water. They're going to appear bright white. On the other hand, though, we do have low proton density tissues. So bone, there's not a lot of proton interaction there. So it's going to appear dark. It should also be noted this can't be used for moving fluids because like blood flow is just, it's moving too fast. The protons are moving too quickly to be detected. And again, this can be processed by a computer. So obviously muscles aren't purple, but you can adjust, enhance, highlight, whatever you need to look at various things. In this case, this is like a rotator cuff injury. You're looking at the various musculature and tendinous insertion points that could be torn. So this is really, really good for soft tissue imaging. It sometimes even gives a better detail than ultrasound. So we definitely like to use this for brain, muscle, tendons, ligaments, things like that. But it does kind of take a little longer. And it's very high cost. So there's limited accessibility. Only very large medical centers and hospitals typically have them. And because it's so expensive too, you kind of have to run through the hoops with medical insurance to get that pre-authorization, which is also why a lot of other imagings are done before this one. So all that being said for our imaging, we have a patient presenting with suspected acute intracranial hemorrhage following head trauma. Which imaging modality is most appropriate for rapid evaluation? And I don't care if someone puts it in the chat or like shouts it out.
And Dr. Hart, can you see the chat? Are you seeing the answers as they come in?
Yes, I just pulled it up right now. Okay. So yeah, most everyone is getting this. So in this case, it'd be computed tomography because we're looking at soft tissue, we're looking for swelling, and we want it done rapidly. If it wasn't a rapid thing, I would probably say MRI, but because we are wanting fast results, CT would be the go-to in this case. All right, now moving on to histology. So we have exocrine glands and endocrine glands. You can see that they both start out fairly similar. Even here you have this cord of ingrowing epithelial cells going downwards for both. The difference is right about here. The exocrine glands are going to remain as a tubule, Whereas the endocrine glands, there is not going to be a duct, there is no tubule, and this cord of epithelial cells will be cut. So your end result is that your exocrine glands are going to have the secretory region, or the secretory portion, and the secretions are going to go through a duct and then be released out of the epithelial surface. The epithelial surface could be like the outer surface of the body, so think of like sweat glands, but it can also be into a body cavity. So sort of think of like organs, secretions going into the stomach, secretions for the uterus. Whereas endocrine glands, without that duct, instead, these epithelial cells and all, they're going to have their secretory region that is going to make the secretion. It's going to be released into extracellular fluid, which gets picked up by capillaries and then distributed throughout the bloodstream. And the bloodstream will distribute it throughout the whole body. So in this case, think more of like hormones. So the pancreas is producing insulin, testes producing testosterone, and it'll circulate throughout the body that way. And then there's a few ways exocrine glands can appear. So morphology-wise, we have simple epithelial glands. I want you to just think of like one secretory region going through a single duct out to that out through that epithelial surface. Then with unicellular glands, this would be like this mucus cell being a goblet cell. It's just going to release straight to the surface as is right there. And then a simple branched tubular, this is where you have multiple secretory regions going through one larger duct and then secreting out. And then mechanisms of secretion. You have three main. The first is merocrine, which is also called eccrine, and then apocrine and holocrine. Merocrine is the most common by far. It's just the cell releasing the secretory product through exocytosis. The cell remains intact during this process. And like I said, it's the most common, so really think of like sweat glands all over the body, the salivary glands within the mouth. Apocrine is a little different because in this case, the apical portion, the top portion of the cell, is going to be pinched off and released with the secretion. So this one is definitely less common. And when you think of this one, think of areas that have an odor associated with it. So these would be like your mammary glands and very specialized sweat glands. So these are the sweat glands for the axillary region, so the armpit, groin, areolar, or nipple regions. And then the last one is the holocrine mechanism. In this case, the entire cell is going to disintegrate and become part of the secretion. It is the least common, so think of sebaceous glands of the skin and meibomian glands of the eyelids. All right, so knowing all that, which type of secretion releases its product by exocytosis while preserving cell integrity? Checking on the chat right now. Yeah, y'all are nailing it. So it is merocrine because the cell stays intact. You're not having an apical portion pinched off or the entire cell disintegrating. So good job. Now we're moving on to connective tissue. So connective tissue is kind of any tissue that is binding, supporting. So you can think of ligaments and tendons being like a supportive structure that's binding. You can also think of tissue wrapping around and separating organs from each other. Also still sort of connective tissue. And there's various things that we can see within connective tissue. You have reticular fibers, which is like the delicate type 3 collagen meshwork that's supporting the structure. Then you have adipocytes, which are fat cells that are storing energy in the form of triglycerides. You have mesenchymal cells, which are adult stem cells that can change into connective tissue. So think of them for repair, regeneration, immune response, things like that. And then we have elastic fibers. These are the fibers that's going to give it like tensile strength. That's going to allow it to expand and snap back to its original shape. And then collagen fibers are the very tough, flexible structures that are really doing the support framework of the whole structure. Fibroblasts to make your collagen fibers. And then you also have macrophages. So think of sort of like white blood cells, phagocytic, I'm butchering words today. Phagocytosis. We'll get there. So think of like infections. And then we are moving on to loose areolar connective tissue and adipose. So over here we have our areolar connective tissue. It's type 1 collagen. You have all these elastic fibers. You got the collagen fibers running through. So collagen fibers, collagen fibers. That's the main supportive network there. It has abundant ground substance and it contains fibroblast, immune cells, and blood vessels. its main thing is to bind epithelium to underlying tissues. So think of skin, how skin is like being bound towards the underlying musculature. It's allowing diffusion of nutrients and waste. And then it's also really important for inflammation and immune responses. And on the flip side, we have adipose tissue. So again, think of like these fat cells. This is a very specialized loose connective tissue. It's got very minimal extracellular matrix, and all the nuclei are pushed off to the side or the periphery, which is why it's often called like a signet ring appearance. And as you can imagine with fat cells, it is that energy storage, like your triglycerides. It's also insulation and cushioning, so it's protecting organs, and it helps with endocrine function as well. And then we have loose reticular connective tissue. So reticular fibers, these are the sort of soft, delicate structural framework setups. They are type 3 collagen. It looks like a mesh. Anytime you see this spider webbing out, think reticular. And it basically is forming the framework for lymphoid and hematopoietic organs. So your lymph nodes, your spleen, bone marrow, those associated. And then we have dense connective tissue. You can have regular dense connective tissue or irregular dense connective tissue. Both are going to be type 1 collagen and both are densely packed. It's just differing on how they're packed. So for regular, all these fibers are arranged in one parallel orientation. And this makes it really, really good for withstanding tension in that one direction. So you see these in like tendons and ligaments and aponeuroses. Whereas on the irregular side, you're looking at all this material right here, which you can see in the drawing here as well. It's haphazard. They're organized every different which way, which makes them really, really great for resisting those like pull, push, tension forces in multiple directions. So still works for structure and strength. And I want you to think of like the skin, fibrous capsules around organs, and submucosa within the GI tract. Okay, tissue. Most people don't think of tissue as a connective tissue. Or sorry, most people don't think of blood as connective tissue, but it is. It just differs in everything else because this time cells are suspended in a fluid matrix and not within fibers. But you have blood as our connective tissue here. Its matrix is just plasma, and we have red blood cells, white blood cells, and platelets, which are our cell fragments. The whole point of blood is to transport gases, nutrients, and waste, and hormones throughout the body. So these are immune defense. You also have hemostasis for clotting. And you can see that blood sort of starts as blood will start here, and it has two different routes it can go. It could become myeloid stem cells or lymphoid stem cells. If you go the myeloid route, this is going to become like red blood cells, platelets, and other associated cells with it. If you go the lymphoid stem cell route, this is going to be like T lymphocytes, B lymphocytes. So here you're looking at your leukocytes, your white blood cells. Alrighty, so for our connective tissue region, so reticular connective tissue differs from dense connective tissue proper primarily by containing which collagen type? Yep, okay. Y'all are nailing it. So it is going to be type 3. There are tons of different types of collagen. For the most part, type 1 is like the most common. It makes up 90% of the body's collagen. Type 2, think of elastic cartilage, so like your ear cartilage, cartilage in the joints, or collagen in the joints. And type 3, muscles, arteries, organs. Your type 4, definitely think of just skin and its different layers, epithelial cells, endothelial cells, the basement membrane. And then type 5 is where you're going to start getting into still some organs like the lungs and the liver and placenta, but this is also going to be part of like the bone matrix and the interstitial matrix of muscles. All right, so moving on to embryology, our last section. We're going to start with just some basic ages. So you can go with gestational or menstrual age, or you can go with fertilization or conceptual age. Gestational age is determined by calculating from the first day of the last menstrual period. So LMP, last menstrual period. And this is going to be where you get the 40 weeks of development from. Fertilization or conceptual age, this is going to be at that time of fertilization. So it's only representing about 38 weeks of development. So on average, your gestational age is always going to be 2 weeks longer than your fertilization age. So knowing that, if the date of the start of the last menses was 10 weeks ago, how old is the fetus now? Yep, your parents got it again. So 8 weeks. It's 2 weeks longer. This is 2 weeks longer than this one. So gestational age, conceptual age. Okay. So why do the different ages matter? It matters very critically for teratogens. So a teratogen is going to be any kind of agent or substance that is going to mess up normal development. So whether it's causing or just increasing the risk of congenital abnormalities when exposed during pregnancy. So these lines here are showing you the greatest time of vulnerability, in this case, the central nervous system. You can see that many of these like initial weeks, the central nervous system can be greatly affected by teratogens. So I just want y'all to take a moment and can you think of any examples of a teratogen? Feel free to put it in the chat. Yep. Okay. So, right, alcohol is a very common one. We also know that viral infections can be bad to get during pregnancy. And then cigarette smoke is not good for anyone either. And then any kind of drugs, whether prescribed or not, could be an effect on. So, what happens if something goes wrong? You can have a numerical abnormality or a structural abnormality. With numerical abnormalities, also called chromosomal abnormalities, this is where you are gaining or losing an entire chromosome. So there are several examples. One of the most common is trisomy 21, known as Down syndrome, because in this case, you're getting an extra copy of chromosome 21. You also have Turner syndrome, where a biological female is missing one X at chromosome. And then you have Klinefelter syndrome, where a biological male is born with an extra X chromosome. So again, a gain or loss of an entire chromosome is happening in any of these syndromes. Whereas with a structural abnormality, nothing is being gained or lost as a whole chromosome. It is changes within a single chromosome. So you can have deletions, duplications, inversions, or translocations, but no matter what, the entire number of your chromosomes is going to remain normal. So when this happens, your abnormality could be balanced or it could be unbalanced. If it's balanced, you're not really gaining or losing genetic material. That's more optimal. Of course, unbalanced, you're going to have missing or extra genetic material present. So some common cases, we have Kruger-Schott syndrome, which is a deletion on chromosome 5. We have Angelman syndrome, which is shown right here. And this is a deletion of or mutation of the UBE3A gene on chromosome 15. So see here, and then here we're good, but then here's just deleted. And then Prader-Willi syndrome, again, a microdeletion or a mutation of a gene cluster on chromosome 15. And then cystic fibrosis is another common one, where we have a mutation of the CFTR gene on the long arm of chromosome 7. So, knowing all that, a female infant is found to have only one chromosome, 45X. This condition results from which of the following? A numerical or a structural abnormality? Okay. It is a numerical abnormality. It's a whole chromosome. All right. So wrapping up with, yes.
This is Dr. Peterson. Just before we move on, there was a question in the chat, and when the students watch the recording, they can't see the chat itself. We don't record that part of it. So I just wanted to make sure that on the recording that we make it clear. The question was about how do we know in a question whether or not the reference is to menstrual age or embryonic age, and I just want it to be clear that we will make that clear in the question stem. We would never ask any of you to guess at that. So the specific question again is what time period of development in the embryonic stage do we answer with gestational age or fetal age? Again, we will specify the answer we're looking for in the question stem. Right, perfect.
Thanks. Okay, So gamete production. So we're looking at production of egg and sperm. So oogenesis is the process of the female gamete being produced. So this is the egg and the ovaries. And then spermatogenesis is the process of the male gamete, so the sperm being produced within the testes. And they definitely differ a little bit. So some major takeaways is that the spermatogenesis process does not begin until puberty. Whereas with the oogenesis, it technically does begin before birth, during the fetal stage, but then it's not going to pick back up again until puberty. Now, this is also going to be over here with spermatogenesis, a continuous cycle. So this will keep going on all day, every day until like death. And then with oogenesis, this is only going to be a once a month thing. And then, of course, we also have it stopping at menopause. So it is not a for life kind of process. Some also key differences here is that at the end of all the mitosis and meiosis stages, at the end of spermatogenesis, you end up with 4 sperm and they're motile. And then if you come over here to the oogenesis side, you're only going to end up with 1 single egg and then a few polar bodies. The polar bodies will just degenerate. They're no longer necessary or used. And of course, the egg is immotile. And then the joining of these will give you the zygote. So when we have our zygote, we're looking at the pre-implantation development. So here's the zygote. It is going to go through a lot of cleavage. It's just rapid mitotic divisions. And this all happens within the uterine or the fallopian tube right here. And it'll end with a morula, which is going to be within the uterus. And the morula is just a solid ball of cells that is going to quickly become a blastocyst as fluid enters the morula. And it's going to push cells very differently within. So we'll have an inner cell mass, which is called the embryoblast. That's going to develop into the embryo. Then you'll have the outer cell mass, which is the trophoblast. That's going to be the placenta and other supporting structures. And this should implant within 6 to 7 days after fertilization, and it should normally implant on the uterine wall, also called the endometrium. However, we know that we do have ectopic pregnancies, which is basically where it implants anywhere outside the uterus. Again, that's most commonly within the uterine tube, but not always. And then week 2, so we have implantation. You can see here, here's the endometrium. Implantation has happened, and we're looking at trophoblast development. So again, we have the embryoblast, which is going to become the developing embryo, and the trophoblast, which is helping with this attachment process. The trophoblast will also further subdivide into 2 groups. So we have the cytotrophoblast and the syncytotrophoblast. The cytotrophoblast is going to be here and here, and it's just this inner cell layer that will continue to merge and replenish the syncytotrophoblast throughout pregnancy. The syncytotrophoblast here is this outer layer that is helping with the whole uterine invasion, the lining of the uterine wall, but it's also going to, again, it's going to help out with those other structures, but it's really for implantation at this stage. So week 3 is where gastrulation occurs. The key thing about gastrulation is that this is where the embryo it transfers from a 2-layer to a 3-layer situation. So the 3 layers, you're going to have the ectoderm, mesoderm, and endoderm. And all these tissues and organs that you're going to have are going to come from these 3 layers. So during this time, you have the primitive streak and the primitive node. The primitive streak is what's allowing the head to tail, this cranial to caudal orientation axis that we have. And that primitive node is helping guide all the development signals here. So when we have these 3 layers, the endoderm is going to go first. I want you to think of the organs. So think like respiratory organs, GI, liver, pancreas, things like that. Your mesoderm is going to come in next. Think muscle, skeletal, cardiovascular. And then the ectoderm is going to be the last bit, and these cells remain near the surface. So think of like skin and neurovasculature, nerves. Now, obviously, this is another stage where things can go wrong. So what happens when gastrulation goes wrong? We have 2 different things. We have a teratoma. So during gastrulation, that primitive streak, it can turn into multiple different types of tissues. If those cells remain rather than disappearing, they become a teratoma. And a teratoma is made from all 3 of those germ layers. So teratomas often have teeth, hair, nails, organ tissue there. And a very common one is this sacrococcygeal teratoma. It's more often found in females rather than males, and it's right here near the tailbone. Usually surgeries can fix that. Then you also have, sorry, okay, I'm going to take a quick drink before I lose my voice entirely. Okay, and then we also have laterality defects. So the body definitely has a very prominent left to right kind of patterning. During gastrulation, this is where things decide, where they're going on those left and right sides. But if anything interrupts this development, you get a few key things. So we have situs inversus, where the organs are flipped, things that are usually on like the left or on the right, vice versa. It's just sort of a mirroring. This situation does not always have complications. In fact, someone can go their whole life without even knowing. And then you also have heterotaxy syndrome, where the organs are really abnormally arranged. This is the situation that does normally cause complications. And this usually happens because the signaling molecule nodal, which is helping with this organization, gets messed up a little bit. So, a sacrococcygeal teratoma may contain hair, muscle, and intestinal tissue. This finding is best explained by abnormal development involving which of the following? All right. You are doing great. It is all three layers. So the hair would be the ectoderm, muscle mesoderm, and intestinal tissue, endoderm. All right, well, these are all the references. All the image references should be on the slides too. And of course, if you have any questions, I'm happy to take them now. I'm going to go ahead and, can I go ahead and stop screen sharing, or shall I keep screen sharing?
You probably should keep your screen sharing going in case there's some slides you want to go back to as kind of a visual aid. There was a
Oh,
question in the chat and I clarified it, but I wanted to make sure that everybody again on the recording can know how I answered the question. It was really where do the cells migrate through when we're talking about the creation of in gastrulation the three primary germ layers? Is it at the primitive node, the primitive streak, or the primitive groove? And I responded in the chat, Dr. Hart, that it's actually the primitive groove. That the primitive node is the starting point that creates the streak, but it's the almost like a cleft in that streak on either side, which we call the groove, where the cells are actually migrating through that. So if you wanted to add anything to that, please feel free. But it looks like, again, we might have some other questions in the chat as well. So you might want to open up the chat. Looks like there's one. Can you point out some key distinctions on how to identify the various types of collagen is one of them.
so for that one, besides, let's see, besides just where you find them, like whether it's a joint or in the ear or wherever. Good question. I'm not sure I'm gonna go ahead.
I can help you out a little bit with this if you maybe want to run your slides and I can talk. So here we are, we're looking at this reticular connective tissue, and everybody should be kind of noticing that the fibers, using just a slightly special staining technique, they're going to stain dark purple, and they're short and they're fatter, and they're creating, as Dr. Hart suggested, they're creating this reticular meshwork. And in Latin, that's what the root word reticula means. It means net-like. If we go to another slide where we can see collagen type 1, I'm happy to point some things out there. So with collagen type 1, and these are both really good examples, the collagen itself is a combination of multiple proteins. So in fact, it's going to have a really large diameter and it stains eosinophilic. So it should stain pink, either light pink, or in the case that you see over on the left, all of those sort of reddish wavy lines are collagen fibers. So this is a really good slide to kind of get a sense of that. With the other types of collagen, the one that I think really we would kind of ask you to at least be aware of would be collagen type 4. And again, as Dr. Hart suggested, that is really specifically embedded in the basement membrane of epithelial cells. So whether they're in a single layer or whether they're a stratified epithelium, you want to go down to the most basal, the deepest layer, and that light pink staining region that has no nuclei, because this is not a cellular material, it's acellular. That's where you would find the type 4 collagen.
Great, right. Let me check in the chat, see if there's anything else I missed. No, I did see someone said they couldn't see the slideshow. I'm so sorry. I don't know why that happened.
But we could see yours, Dr. Hart. So I mentioned to that student that they could try to, jump out and come back in, and then also where they could find the recording and where we're going to post your slide deck. So I hope Jaden's all set.
Okay.
Okay.
I don't see anything else. Yep, I think that was everything. Can you let me know if I missed anything? It looks like we got all the questions.
Okay, so one more I see about collagen type 4 can be, okay, so I'll just go ahead and answer this one as well. So would collagen 4 be located underneath the basement membrane or above it? And here's what I'm going to tell you, it's in it. So the goo that is the basement membrane. So membrane is really a misnomer here. The goo that is the basement membrane is kind of fortified with type 4 collagen fibers. So I hope that helps.
Alrighty. Well, thank you guys for listening. Y'all answered everything really, really well. So I'm going to go ahead and stop sharing it.
Perfect. Dr. Hart, thank you so much for being with us. Let me go ahead and introduce our next presenter. This is Dr. Celine Cortez. She earned her bachelor's degree in biology from the University of California at Los Angeles. She taught English in Japan for 2 years before returning to the US to continue her educational journey. She earned her PhD in biomedical sciences with a specialization in anatomy and vertebrate paleontology from Oklahoma State University Center for Health Sciences. Her dissertation research focused on the ecology and skull morphology of historical wolves and coyotes of the American Southwest. She's currently an assistant professor of biology at Central Washington University in Ellensburg, Washington. In her free time, Dr. Cortez enjoys hiking and watching movies with her husband and their 2 dogs, Happy and Zeus. We're so glad to have you with us tonight, Dr. Cortez. Please feel free to start sharing your screen.
Perfect. Yeah, thank you for that introduction. So I'll go ahead and share my screen. Okay, can everybody see that okay?
We can.
Okay, perfect. Yeah, let me put that in presenter mode too.
Perfect.
Okay, so
Awesome.
I'm going to go ahead and present on basically the musculoskeletal system as a theme, but really it's kind of touching on different systems and then a little bit of embryology as well. So let me just make sure I'm keeping track of time. Okay. There we go. And so these are some of the regional objectives covered. So, for the sake of time, I couldn't cover all of them, but I'll try to cover and talk about like kind of as much as I can. And then one thing I do want to mention too is that relative to Dr. Hart's presentation, mine's a little bit switched. So I actually have the knowledge check questions first, and then I'll kind of go back and talk about and review some of this information. So I'll give you an opportunity to answer this question here. So go ahead and see what you got for this knowledge check one. Okay, and I'm seeing some good answers in the chat. And then Dana, I just want to make sure The chat isn't showing up, right?
I don't believe it is exactly, but you
Okay.
know, yeah.
Yeah, I just want to make sure. I can see it on my screen, but I just wanted to make sure it's not blocking anything. Okay, perfect. Alrighty, I'll continue on. Okay, so
Okay.
for our knowledge check, you all did very well. So this is essentially just a little rundown of the different regions of the vertebrae or the vertebral column. So when we're looking at the vertebral column, we divide this into different regions. So starting superiorly, we've got our cervical region towards the top, right? So that's more superior. Then we've got a thoracic region, really corresponding with essentially where ribs are attaching, right? So the thorax, lumbar region, we associate that with the back and kind of like that lower back, right? And then we've got kind of our sacral region, so kind of more pelvic area, right? And then coccyx down here. So a couple things that can be pretty helpful in terms of um, looking at the different types of vertebrae. For most of the cervical vertebrae, not all of them, but most of them have something called a bifid spinous process. So that essentially means that spinous process, which is that part of the vertebrae that's projecting posteriorly, there's quite a few of the cervical vertebrae that have like a little split going on there. Um, and then another thing that some of the cervical vertebrae have is this transverse foramen. So a transverse foramen on either side of the vertebral body in the middle. And this is essentially where the vertebral artery actually runs through and travels up onto the brain. So those characteristics can help you identify at least a good portion of the cervical vertebrae. As you may be familiar already, kind of our atlas, so C1 and C2 are a little bit special. So they don't quite have these same features, but they're really weird in and of themselves. So they've got some kind of unique features going on there, like Atlas, the first one there, lacks a body, right? So it's got some pretty cool stuff going on. And then as we move down to thoracic, they usually describe the body as being bean shaped. So it kind of looks like a kidney bean a little bit. And then we see that spinous process tilts kind of down, so more inferiorly. And then lumbar vertebrae, those spinous processes tend to be pretty short and fat. And then we've got these little processes on the side called mammillary processes, where some of those erector spinae muscles will attach onto. And then for sacral and coccygeal, typically we've got fusion going on. So all the sacral vertebrae, there tend to be 5, and they tend to all be fused. And the coccygeal oftentimes tend to be fused as well, and we can have some variation in the number, but essentially these all typically fuse together, and we refer to that fusion as the coccyx. So that's what we colloquially call the tailbone. So that's just a little overview of how to remember some of those differences in kind of the regions. And then I will also mention that sometimes you get a little bit of transition, or there's similarities kind of going on in the transition region. So sometimes it can be a little bit challenging to tell maybe like T12 versus L1 apart, but hopefully they'll be nice and kind to you and pick a representative somewhere in the middle that has like typical features. Okay, so to move on to knowledge check number 2. Okay, knowledge check number 2, go for it. Yeah, I'm seeing some good answers there. So I'm going to go ahead and move on. Yeah, so the answer in this case is B, the lateral collateral ligament. So a couple things, just going to kind of review some of these different ligaments going on here. So kind of starting off here, I do want to start kind of the review of these different ligaments of the knee and knee joint going on here, and that the patellar ligament is one of the major ligaments of this joint. And the patellar ligament is also sometimes called the patellar tendon. You may have learned this before, but the patella in itself is a sesamoid. So a sesamoid is a special type of bone that appears within a tendon or like grows within a tendon. So sometimes this is listed as the patellar tendon because the patella itself is a sesamoid embedded within the tendon. So it's kind of assuming a continuation between the quadriceps tendon all the way down to the tibia down here, and that forming kind of like a continuous tendon. But we can also sometimes, or this is also sometimes referred to as a patellar ligament because this is technically a bone-to-bone connection from the patella down to the tibia. So just keep that in mind. Those sometimes are used interchangeably, and that just has to do with the fact that the patella is a sesamoid. And then we've got our collateral ligaments. So collateral ligaments are found on basically the sides of the joint in this case. So there's a medial and lateral collateral ligament. So the medial, or also called the tibial collateral ligament, is found, as you can imagine, more medially, right? So it's going to be found, it's this medial connection between the tibia and the femur. Where our lateral collateral ligament is really going to be that connection between our femur and the fibula out here. So that's why it's also known as the fibular collateral ligament. But oftentimes these are abbreviated and referred to in clinical settings as like MCL and LCL. And then another thing to note is if you remember that the fibula is more lateral, like when we're thinking about the orientation and like relative positioning of those bones, that should kind of remind you about the lateral collateral ligament attaching on to the fibula. And really their job is to make sure that we're not having a ton of lateral and medial movement. So it kind of acts as a barrier and just helps secure things in place. And then we also have our cruciate ligaments. So cruciate actually means cross. So these ligaments do cross. They do form this like X pattern. And the purpose of these really is to help prevent too much anterior and posterior movement of this joint. So anterior cruciate, the ACL is going to be this one right here, where from an kind of like an anterior or anterolateral view, posterior cruciate, we can't see quite as well. But essentially, those are just making sure that our knee joint isn't shifting too far forward or too far backwards. And so those are just helping provide some stabilization. Okay, I'm seeing some questions here. If someone says ACL and LCL, yeah, so ACL and LCL, you kind of just have to know the actual meaning. So this the MCL, you just kind of have to be familiar with the fact that they are referring to the medial collateral ligament there. And the anterior cruciate ligament is going to be ACL. So it's really kind of just about knowing the acronym. Yeah, it takes some getting used to, but yeah, if you get those acronyms down and you kind of know what they mean, that then you're kind of on the same page. Thanks. Okay. So yeah,
Dr.
that's kind of an
Cortez.
overview of those different ligaments. And again, they're just kind of supporting knee function, making sure things aren't like moving too far in any given direction. And yeah, this is also a hinge type joint as well. So you'll probably come across a couple different types of joints. This one would be considered a hinge, so it closes and opens like the hinge of a door. So that's just some little extra information about this one. Okay, so on to knowledge check 3. Okay, I'm seeing a mixture of different things going on here. Let's see. Okay, so starting with this first picture, so a superficial back muscle that attaches onto the vertebral column via the thoracolumbar fascia best describes latissimus dorsi, actually. So as a reminder, latissimus dorsi is this expansive muscle back here that's very superficial. And if you're not familiar, the thoracolumbar fascia is a type of aponeurosis. So an aponeurosis is essentially a specialized kind of sheet-like tendon that helps oftentimes like pretty expansive muscles like that attach onto different structures. So this is really how the latissimus dorsi is attaching onto the vertebral column and even like kind of down here onto the pelvis. So it is attaching directly onto the thoracolumbar fascia to make this connection here. So erector spinae, I saw that as a common answer. So erector spinae is actually deeper. So it would be deep to latissimus dorsi. So we wouldn't actually be able to see really erector spinae, which runs up and down the spinal column here until we actually remove or like reflect latissimus dorsi and remove a lot of this thoracolumbar fascia. So the thoracolumbar fascia also is superficial to the erector spinae muscles. And then we've got trapezius up here going on, and then rectus abdominis we can't actually see in this picture right now. So moving on to this next picture. So this is just a little bit of a reminder about some of those actions and then some of the other muscles that we have going on in this area. So now this is a posterior view, right? When we're looking at back muscles here. So this one over here is an anterior view. And I see a question, what's the difference between aponeurosis and fascia? So that's a great question. So aponeurosis is really typically considered a tendon. So it's a specialized type of tendon that's helping muscle connect onto some structure, often skeletal structure, where deep fascia or fascia usually envelops over the surface of muscles in some fashion, or sometimes it runs kind of in between muscles. But aponeurosis, you really want to think of tendons. Yeah, so they're both connective tissue, but they're serving kind of different functions and purposes.
Maybe Dr. Cortez, it's Dr. Peterson, if I could just add.
Yeah.
And then the students in medical school are taught that a tendon is really connective tissue that's attaching muscle to bone. And then Dr. Cortez reviewed that a ligament attaches bone to bone, and then aponeuroses are usually broad sheets of connective tissue that will connect a muscle to another muscle. And that could be from the front of the skull to the back of the skull, or in this case, the rectus abdominis muscles from the right side to the left side. So maybe that's helpful too.
Yeah, thank you. And then, yeah, so we've got on this image here, we've got rectus abdominis going on here. So there is another aponeurosis here called the rectus sheath. And as we reflect that rectus sheath, that's actually when we start to see rectus abdominis going on here. And then we've got external abdominal oblique on the side here. And then these are just a little reminder about some of the different actions of these muscles. So if you think, I think one thing to remember is muscles are always pulling, they're never pushing, right? So if you kind of get familiar with the different things that they're attaching onto, just keep in mind they're going to get shorter in general as they contract, and they're going to pull on whatever they're connecting onto. Yes, so rectus sheath is superficial to rectus abdominis. So you have to reflect this out of the way to actually see rectus abdominis. So it's reflected on the on this patient's left side, but it's present on this patient's right side in this image. Okay, I'm going to move on to knowledge check 4. Okay, so where does interstitial cartilage growth occur? Okay, let's go ahead and talk about this one. Okay, so this is just a little bit of review on how cartilage grows and some of the cells that are involved in the formation of cartilage. So like other tissues, we start with an embryonic precursor, in this case, mesenchymal cells. So these are kind of like our embryonic stem cells that have the capacity to differentiate into different things. So we kind of heard them talked about already. So mesenchymal cells can differentiate into chondroblasts, which can then differentiate into chondrocytes. And these all kind of play different roles in the formation and maintenance of cartilage. So some important things to note here when we're thinking about cartilage is the different areas and different kind of sections of cartilage in and of itself. So when we're looking at cartilage in a histological image of cartilage, we've got the perichondrium, that is more kind of external, really. So the perichondrium is kind of this denser connective tissue area that's a little bit more external. Then we have what's known as the chondrogenic layer, and this is really where chondroblasts are hanging out. So this is where we have this collection of chondroblasts that have the capacity to then differentiate into chondrocytes. And then, yeah, let me respond to something really quick. Okay. And then, so chondrocytes, we've got those going on in here. So chondrocytes, these are basically the mature cells. They sit in little lacunae, so little capsules going on here. And chondrocytes, the little lacuna, this little kind of cavern that they sit in, tends to stain a little bit dark. So you can actually see a little ring around these mature cells. And these mature cells will be more internal within like the cartilage mass, it's typically called. So the cartilage mass is referring to this more internal area of the cartilage itself. And so really all of these pictures are showing hyaline cartilage. And hyaline cartilage is really that type of cartilage that we find in different joints, tends to have kind of pretty good properties in terms of, so the cartilage mass contain lacunae. Yeah, correct. So lacunae are just the spaces in which the chondrocytes are sitting. Yeah, so this is cartilage mass area. And basically, the big takeaway here is that interstitial growth is really when we have these chondrocytes, these mature cells undergoing mitosis inside of their lacunae, and then they secrete matrix. And when they're secreting matrix, they eventually separate from one another. And so interstitial growth is really more internal within the cartilage mass, where appositional growth really involves growth often in width, and then the mesenchymal cells, this is where the mesenchymal cells are within the perichondrium are differentiating into chondroblasts. And then cartilage grows at its surface versus interstitial, where that growth is more within the cartilage mass. And that's kind of the big takeaway there. Okay, so I'm going to move on to knowledge check number 5. Okay, doing good, nice. So yeah, for knowledge check number 5, kind of the review is pretty simple going on here. So the important things are to be familiar with the appearance of woven bone versus like mature bone. So woven is really the immature bone. This is bone that's typically laid down pretty fast, or it's found in the developing fetus as well, or even in adults when we have bone remodeling occurring as part of like normal repair or different processes like that. We initially start with woven bone, and that later gets remodeled into things like mature or lamellar bone. So this is mature or lamellar bone is also really like compact bone. So if you're familiar with kind of the different divisions and different types of bone, this is really compact bone here. And then keep in mind there's lots of like collagen fibers. It's really not well organized, and that's one of the big things here. So this darker kind of staining area is referring to the areas of the bone. So it's really kind of spicule-like and generally just not as organized as something like mature or lamellar bone. Okay, so moving on to the next. So this is kind of more, or still really on the topic of bones, just looking at some of that composition a little more closely. Nice. Yeah. So it looks like everyone's on the right track. All of these are true. So Haversian canals are really these little spaces within the bone at the center of are osteons. So osteons are really referring to kind of the basic functional unit of mature bone. So this is like mature lamellar bone in this case. And we have basically these different rings of compact bone with mature cells, so osteocytes, kind of found in between those concentric layers. Um, and essentially, the big things to remember here is that we do have really vessels as well as nerves happening within the Haversian canal there. So that's really an important part of making sure that bone can get the nutrients it needs, and also has a mechanism for detecting things like injury and repair. And osteocytes are also kind of involved in that process. They kind of can help detect whether or not something has happened to bone, and they can signal other cells and communicate with other cells to say like, hey, there's we need to make some repairs, and kind of recruit other cells to take care of that. And then, so just something else to note here is that, again, here's our osteon, like a single unit here. We have our concentric lamellae, and then this would be our periosteum towards the outside of the bone, and endosteum towards the inside of the bone. So this part's towards the medullary cavity. Yeah, and for the sake of time, I'll just kind of keep on going, and I'll make sure if we have time at the end, I'll try to answer some more questions. Okay, knowledge check 7. Okay, so the answer is B in this case. Really nice. So this is which part of the neuron communicates with a muscle cell. So this is really just asking what part of the actual neuron. So what's that piece called that's making that connection with a muscle cell? So just keep in mind that this has a couple different names. So sometimes it's called synaptic end bulb, sometimes it's called synaptic terminal. That's referring to the same thing. And this is really just the very end of an axon that is kind of bulbous in shape. And this is the portion of the neuron that contains neurotransmitters. So neurotransmitters are just those chemical signals that allow neurons to communicate with other cells. And what's not really shown here is there's voltage-gated calcium channels that actually stimulate these little vesicles that contain neurotransmitter to then merge and release neurotransmitter into this space called the synaptic cleft right here. So yeah, I would say be familiar with the fact that the neuromuscular junction is really this connection and this communication between the synaptic bulb and a muscle cell. And then in this case, the important neurotransmitter is acetylcholine. And then in histology, like in a histological slide, what we end up seeing is really like a motor neuron kind of just looks like these different little strands that end in little bulbs along these kind of different striations of the skeletal muscle going on here. So this is really the neuromuscular junction here, where we're seeing the synaptic bulb kind of contact a muscle cell.
And Dr. Cortez,
Yeah.
Dr. Peterson again, I'm just going to interject because year after year, Anato-Bee participants have asked or been confused by the concept of a motor end plate and
Mm,
where it is between these two cell types. So maybe
sure.
we just review that really quickly because that's important.
Yeah, yeah. So this is the motor end plate right here. So this is essentially the part of the muscle cell itself that contains these different receptors for acetylcholine. And then those receptors are going to allow ions to pass into essentially the plasma membrane of the muscle cell and create that movement of ions sort of deal. Okay, so I'm going to keep on going, and then if we have time, I'll answer some more of those questions. Okay, so knowledge check 8. Okay, doing pretty good. Yeah. So this is really just talking about like kind of the differences in muscle cells and then muscle histology also, and how they appear on histological images. So this is just a little overview that you are welcome to kind of reference back to as you're looking at these different images, but in essence, some of the important things to keep in mind and ways to distinguish between these different types of cells is skeletal muscle. We typically see that the nuclei, which are staining darker here, are on the periphery of these types of cells. They also have striations, so we can actually see these like little wiggly lines known as striations. And this has to do with the fact that the actin and myosin molecules and that kind of stuff are arranged in a specific pattern, and they're arranged in sarcomeres. So those little filaments that you may have learned about before, but this really just has to do with the arrangement of actin and myosin filaments within a muscle cell. Where cardiac muscle, these darker ones here are the nucleus in this case. And a good way to recognize this kind is you see these little intercalated discs. So there's one right here, which is a pretty good one. We can also see like some over here. And intercalated discs are essentially just these areas of connection between the cardiac muscle cells. They're branching and like coming together, and that essentially just helps cardiac muscle contract together as a unit when we think of separate chambers. So that those connections, those intercalated discs there, just make sure that the heart, when it is performing its physiological functions, is able to contract as different units. So especially the chambers together, so the atria and the ventricles together. That's something that helps cardiac muscle perform that function. And then our smooth muscle down here tends to be more fusiform in shape. So that just means kind of spindle shaped. So it's a lot more, it looks kind of like it's stretched out, and the nuclei are very centralized. Okay, continuing on. Okay, and this will be the last question. Okay, so the answer here is C. Very nice. So yeah, for this one, this is really just about thinking about embryology, right? And then up here in this particular diagram, we're really starting from around week 3. Well, week 3 is really when we're starting to get that folding and the appearance of these different embryonic layers, so through gastrulation. So the ectoderm, mesoderm, and endoderm showing up, and then this is really starting to talk about further differentiation down here. So paraxial mesoderm is really kind of this cluster of mesoderm that's showing up by the neural tube, and that paraxial mesoderm then differentiates into segments called somites. So we can see a somite in this image right here. And so this is just a little schematic that a previous instructor created, which I'm very grateful for. So here we can see the somites, so these blocks of mesoderm adjacent to the neural tube. These are going to further differentiate and kind of separate into different components going on here. So we've got dermomyotome and sclerotome, and these components form different things. So dermomyotome is going to form skeletal muscles and skin, and then the sclerotome is going to form vertebrae and ribs. And then we get further differentiation into different components there. Okay. Dana, I think we're probably at time, so I don't want to keep you too long. So should I stop sharing?
Yes, please. Yes, and we are so grateful again for the fabulous job you did in just taking students through kind of step by step some of the most important concepts associated with musculoskeletal systems. So again, thank you so much.
Sure.
I saw that Dr. Mehay was here, Mehay. So if you would like to turn on your camera, I would be happy to go ahead and introduce you. Um, an assistant professor from the Department of Medical Education at Sidney Kimmel Medical College at Thomas Jefferson University, teaching broadly across gross anatomy, microanatomy, embryology, and neuroanatomy, all the things that we're asking the students that participate in the anatomy to know a little bit about. He is also a co-director at KMC, in which he oversees the faculty and content of both cardio and pulmonary blocks at Jefferson. He received his PhD in anatomy at Pennsylvania State College of Medicine at Hershey, where his research focused on angiotensin 1 through 7 and neural mechanisms controlling energy balance. He lives in Philadelphia and is excited to be a part of the anatomy today. And we are excited to have you. So if you wanted to start sharing your screen, that'd be fabulous.
So I'm not,
We're not seeing it quite yet.
yeah, sorry. Uh, I might have to log in and log out. There's a setting that's not letting me share.
Okay.
Sorry. There we go. Is that working now?
It is.
Okay. Where is it? We went from Zoom to Teams recently, so now it's like not update. Like my Zoom app has gone by the wayside. Okay,
Well,
so can you see
just
my
grateful for you. Yes, we can. And we're just grateful that you're here tonight.
awesome. Okay. So here were the lecture learning objectives for anatomy, histology, and embryology. I'll let you, read those, but those are what you guys are focusing on. So I just have some questions based off of these things. Um, so I have a question here. If you guys want to, where's the chat? There it is. Okay, looks like that was pretty simple. So experiencing difficulty with spatial awareness, and interpreting sensations such as touch and temperature. That is going to be in the, I'm just going to move it along with this one, parietal lobe. Correct, everybody. So frontal lobe is going to be more executive function, voluntary actions, planning, thinking, whereas our parietal lobe, which was the correct answer, is somatosensory, temperature, pain, taste sensation. Whereas the temporal lobe is going to be, I always remember it's right next to your ears where the temporal lobe is. So it's going to be doing auditory perceptions, with some memory storage and smell and taste as well. And then the occipital lobe, the lovely back of your head, is where you're going to get visual perception and recognition. Okay. So we can see that here. Sorry. It's like putting the chat in my in my way to move stuff around. So again, the parietal lobe was the correct answer here. Here we can see some different gyri. So we have our post-central sulcus. So this is going to be the primary somatosensory cortex. We have the secondary sensory cortex, which is going to be more posterior in the brain. We have an integration cortex, so that's integrating these hearing, vision, somatosensory information. And then we have the borders being our central sulcus, so between my primary postcentral and precentral gyrus. And then we have our lateral sulcus, separating my parietal from my temporal lobe, and my longitudinal fissure, which would be separating the hemispheres, which we cannot see here. We don't see any questions, so we can move to the next one. So after a stroke, a patient can understand everything said to them, but struggle significantly to physically produce speech as a form of complete sentences. Their speech is slow, labored, and a condition known as aphasia, which lobe of the brain was most likely damaged. Yeah. Okay. Looks like everyone dropping A into the chat. And that is going to be correct. So A is going to be the frontal lobe, but more specifically, I wanted to get at Broca's area. So this is going to be responsible for the motor movements required to speak. So putting words grammatically correct in sentences. So damage to this frontal lobe or Broca's area specifically is going to cause broken speech. Um, Whereas if you looked at Wernicke's area, this is going to be a junction of all of the parietal, temporal, and occipital lobes. And this would be if you were to damage Wernicke's area, this would be comprehension of language. So the damage, you would still be able to speak fluently. It just wouldn't make any sense to us. So it'd be just saying kind of random words in random order. I don't see any questions. Okay. So again, here we can actually see these. So these language centers are going to be on the left hemisphere. So specifically my Broca's area here, and then my Wernicke's area here, that kind of junction of those parietal, temporal, and occipital lobes, making my Wernicke's area, and then my Broca's area being in the frontal lobe. Okay, a histology of the neuroscience. So neurotransmitters are primarily stored within vesicles. In which part of the neuron are these vesicles found at highest concentrations? You guys have been studying. So correct. C. So the question was about which part is the vesicles going to be stored in. That would be at the synaptic terminal. So this is going to facilitate that rapid release of chemicals, whereas the dendrites are receiving the electrical signals from other neighboring neurons. Soma is going to just be the cell body, is containing our membrane-bound organelles. And then myelin sheaths are to insulate the axons for faster signal transduction. And we can see all of these here. So here's my classic neuron structure. So we have my cell body centrally located, or as my soma. We're going to have dendrites. So these are going to be taking in information. Um, and then our one axon, our axon hillock, is going to integrate that signals and then decide once it fires. It fires our action potential. And then we are going to go down um, myelin sheaths along our swan cells because we're going to be, in this example, a um, alpha motor neuron. So this is going to be in your peripheral nervous system. And then our synaptic terminals, the correct answer, is going to be sitting down here at the end of our axon. Okay, another histology question for us. Two different types of glia cells. Cell A is found in the brain and is responsible for producing the myelin sheath that insulates multiple axons. Cell B is found in the peripheral ganglia and provides structural and metabolic support to neuronal cell bodies. So the correct answer is B. So oligodendrocytes are going to be within our brain, so our central nervous system, whereas satellite cells are going to be in the peripheral nervous system. And everything else is a combination that does not match the central nervous system and peripheral nervous system for cell A and cell B. So we can see that here. Within my central nervous system, astrocytes are going to be within the central nervous system. Oligodendrocytes are in the central nervous system. Ependymal cells and microglia are all going to be within the central nervous system, whereas in the peripheral nervous system are our Schwann cells and our satellite cells. Our Schwann cells are going to be the main form of myelination for our peripheral nervous system, whereas oligodendrocytes are the main myelination for our central nervous system. Hopefully clears that up. It looks like we had quite a bit of multiple answers coming in. Does that make sense to everyone? Hopefully. Can't see anything, so I'm just going to assume yes. Okay, I have an embryology question for us. So during a prenatal ultrasound, a fetus is diagnosed with anencephaly. Anatomically, this congenital anomaly results from failure of which specific developmental process? Fantastic. I'm seeing a bunch of answers. So the correct answer is going to be A, so failure of the cranial close, in contrast to the caudal neuropore, or both. So anencephaly is specifically of the cranial neuropore. So as we can see here, spectrum of malformations are related to cranial end of our neural tube. So you can have anencephaly. So this is a complete absence of brain and a failure of the skull to form. So this is, an incompatible with life, no brain, no skull. Um, Moranocephaly is going to be partial absence of brain. It's going to be more common than a complete anencephaly. And then excephaly is the brain is present but is exposed, so the skull did not close. That is in relationship to spina bifida, which is the failure of the caudal end of the neural tube, the caudal neuropore to close, resulting in vertebral arch malformations. So this is usually an exposure or protrusion of spinal cord and meninges. So you can have multiple types down here. You can see where their differences is this one, spina bifida occlusa. It's just going to be the vertebral arches are unfused. And there's quite often an overlaying tuft of hair at this location, right at the lumbar location. Um, and then meningeocele and myelomeningeocele are just that the vertebral arches are unfused, and then either there's meninge within a protrusion, or there's meninge and spinal cord within the protrusion. Um, I only had these handful of questions for you guys. Um, so that was all that was all I was had to presentate. Hopefully, yeah, is there any questions or anything else I can do for you guys? Um, is that protrusion in the anterior posterior? So it would be posteriorly. So if we go back, this would be anterior. This would be posterior for both, like for all the images. This would be anterior, posterior, anterior, posterior, anterior, posterior. So the vertebral arches are posterior, where the vertebral bodies are anterior. So it would be a protrusion posteriorly because those arches did not close. Does that hopefully answer that question? Part of the brain is exposed. That's going to be our excephaly. Okay, got it. Great.
So I I don't think that there'll be any more questions, but if you wanted to just stay with us just for a couple more minutes, see if any others come in. And in the meantime, I'll just remind all of you that are watching, whether it's right now or watching the video recording once it gets posted to sometime later tomorrow. Um, a reminder for the regional competition, you should really now be focusing on the regional competition learning objectives for all three of our anatomical sciences content areas. So anatomy, histology, and the embryology. But I wanted to make it clear that it is still fair game to hold you accountable for those local competition objectives. So don't forget about going back and reviewing those every now and again. And we'll have more information on our final regional competition tutoring session going through how the competition is structured. I see that one of the questions is what is the proportion of regional to local test materials? We're not going to actually divulge that. It's just to say that we can ask you some of those local competition learning objectives. But we'll talk more about and give you a better idea about the standardized patient experience in the regional competition, what you should expect for that. Talk a little bit about the actual on the donor body lab practicals, give you some ideas about that. There is a video that was made by some medical students that's posted on the website. You may want to start reviewing some of their strategies for how to approach the lab practical, but we're going to help you out with that as we get closer to the March 14th, 15th date. If any of you have any last questions for any of our presenters, now would be the time to ask. You could either put it in the chat or you could, use your icon and raise your hand. I'm sure they'd be happy to answer any final questions. All right, why don't all of you use the reaction button and show our presenters how much you enjoyed and appreciated their time this evening, spending it with you. Yes, thank you. Thank you all. Appreciate that. It was good to see all of you again here in real time, and best of luck with your preparations, and we'll see you. I believe our next regional tutoring is in 2 weeks. That's going to be February 22nd. So take care until then.